So here I'm going to discuss about the pneumonia and bronchitis and bronchiolitis. Bronchitis, it is the inflammation of the trachea and bronchi. It may be referred to tracheobronchitis. So in this picture, we can see the respiratory tract, trachea, then bifurcated, one for left, one for right. We call bronchus or bronchi, and this one is called bronchioles. So when the trachea or bronchi or bronchus is inflamed, we call bronchitis. What else? The bronchiolitis. This is the infection of bronchi or bronchioles. And this infection causes by respiratory syncytial virus. And usually, if the patient has bronchiolitis, usually patient present with fever, cough, or rhinorrhea. If you put the stethoscope over the lungs, we can get wheezing. What else? In case of bronchitis, it is usually occur associated with upper respiratory infection and usually mild disorder. Underlying cause or agent are the usually virus or viral. So what are the signs and symptoms? Fever, dry or hacking cough, non-productive cough that is hoarse at the night and become productive in 2 to 3 days. In this picture, we can see the lumen in respiratory tract, normal here. But in this picture, we can see the narrow the lumen because of inflammation, too much secretion, the pathway getting narrower in case of bronchitis. Next here, what if your patient develop the bronchitis? What are the intervention or nursing care? We provide the humidified oxygen or always keep the suction equipment at bedside or suction nasopharynx, encouraging fluid intake. It is the target. What else? We go for the assessment. First, what patient need and treat the symptoms as necessary. Monitor respiratory distress. We check the saturation of oxygen by pulse oximetry. If it is less than 95%, we give them oxygen. This is the most priorities. Provide cool and humidified oxygen. Encouraging increase the fluid intake. Child may drink beverages that he or she likes as long as respiratory status is stable. Give them antibiotics because of fever, or medication may be prescribed to promote the rest. Now here we're going to bronchitis and respiratory syncytial virus. It is an inflammation of bronchioles that causes a thick production of mucus. which occlude the bronchioles or tube and get the lumen narrow and small bronchi. Respiratory syncytial virus is an acute viral infection and a common cause of bronchitis. Other organism that causes the bronchiolitis include adenovirus, parainfluenza virus, and human metapneumovirus. Right? So it is infection of the lungs by the virus, but infection of the lungs, if caused by Staphylococcus or Mycoplasma bacteria, we call bacterial pneumonia. But here we are talking about the infection by virus. So respiratory syncytial virus, although not airborne, it highly communicable and is usually transferred by direct contact with respiratory secretion, right? So also it is most commonly occur during the winter or during the springtime, right? Also children under the 2 years old, they are frequently attacked by this virus. So the RSV is contact precursor. So if we see anybody is infected by respiratory syncytial virus, we have to follow the contact precursor, like we could wear the gloves and gown, give them private room, and also we remove the gloves and gown before leaving the patient room, right? So contact precursor sometimes spread by direct or indirect. So if you contact with any infected client, it is easy to spread. And indirect contact means contact with contaminated surface. So when we cohorting the patient, it is important cohorting with the same organism, right? What else? So they said, at the risks of children include those older than 1 year of age who have a chronic or disabling condition. Identification of virus is done via testing of nasal or nasopharyngeal secretion. Prevention measures include encouraging the breastfeeding, avoiding the tobacco smoke exposure, or using the good hand washing, and also admin the pelivozumab, means antiviral or monoclonal antibody. To high risks of infant, they need antiviral to administer via transmuscular injection, right? Antiviral, because it's the virus. Now here, what are the signs and symptoms if anybody is infected by respiratory syncytial virus? Patient present with rhinorrhea, eye or ear dryness, pharyngitis is infection in the pharynx, right? So maybe the infection in nasopharynx or normal pharyngitis. If infection the upper airway with Staphylococcus aureus, we call staph throat. It is bacterial, but maybe patient present with this coughing, sneezing, or wheezing. Wheezing, if you auscultate the lungs, you can get wheezing. Intermittent fever. So temperature go up and down, intermittent. In the disease progress, we get increase the coughing or wheezing, sign of air hunger, baby struggling for the oxygen, trachypnea, and retract the intercostal muscle. Also, patient develops cyanosis. If our patient has a bronchiolitis because of respiratory syncytial virus, what are the intervention? For the child with bronchiolitis, intervention are aimed at the treating the symptoms, include airway maintenance, humidified air and oxygen, adequate fluid intake, and medication. For hospitalized child with RSV, isolate the child in a single room or place in a room with another child. Ensure that nurse caring for the child with RSV and do not care for other high-risk children. Use the contact and standard precursor because it is the contact precursor. We have to follow universal precursor. It means uses for care of the children, or client to prevent the direct contact with all body fluid. Standard precursor routinely practiced by the healthcare provider. It includes hand wash and don the gloves. Ensure the nurse caring for the child with RSV do not care for other high-risk children, right? Monitor airway status and put the patient bed 30 to 40 degree angles, positioning of the child. It helps for respiration well. Provide the cool, humidified oxygen and monitor the pulse oximetry, encouraging enough fluid. Periodic suctioning may be necessary if nasal secretion are a lot or copious. Assist the admin of antiviral. It is called ribavirin. Also cough suppression or administer with caution because they can interfere with the clearance of respiratory secretion. Now let me talk about pneumonia. Pneumonia is the inflammatory parenchyma or alveoli caused by virus or caused by mycoplasma agents, bacteria, or respiration of the foreign substance. The causative agents usually is introduced into the lungs through the inhalation or from the bloodstream. the viral pneumonia occur more frequently than bacterial pneumonia, particularly in the children. Primary atypical pneumonia usually caused by Mycoplasma pneumoniae or caused by Chlamydia pneumoniae. Some books said it is occurred by Streptococcus or Mycoplasma pneumonia. Mostly occur often in fall or winter because more people exposed to the public, people gathering in winter in some place, right, or fall. In this picture, we can see this is the normal lung alveoli, but in case of pneumonia, we can see here infection in the lung alveoli because of this organism. So in this definition, you say infection requiring bacterial pneumonia, often serious infection. Here, secretion, liquid materials enter the lungs and causes the inflammation, and chemical pneumonitis developed. So in case of pneumonia, here we can see excess secretion, lumen is narrow, and they are dilated and does not go back repositioning, dilated. So bacterial pneumonia is often a serious infection requiring hospitalization when pleural effusion or emphysema accompanies the disease, right? So hospitalization is also necessary for the children with Staphylococcus pneumonia. So aspiration pneumonia occur when food, secretion, liquid or other materials enter the lungs and causes the inflammation and a chemical pneumonitis. So as I told you, pneumonia is the inflammation of the lungs or infection of the lungs. The underlying cause, aspiration, bacteria, viral, even fungal. Protozoa also can cause pneumonia, but Mycoplasma is most common. Keep in mind, bacterial pneumonia require isolation within 24 hours after starting antibiotics. Viral does not need isolation, right? So the classical symptoms include increasing cough and fever with a foul-smelling sputum and deteriorating result on chest X-ray and other sign of airway involved. So most common sign symptom, patient develop fever, air is showing, data collection, patient present with fever or shortness of breath, we call dyspnea, pleurotic pain, or productive cough. Patient develop trachepnea, night sweat. If you check the blood count, CBC, WBC going up, right? And also how we get diagnosis. We go for the chest X-ray, we go for blood gas analysis and sputum culture before start the antibiotics. Let me read it. Acute or insidious onset, suddenly occur. Patient present with mild fever or slight cough, malaise to high fever, severe cough, or sweating, diaphoresis. Non-productive or productive cough of small amount with white sputum, wheezing or fine crackles we found during auscultation. Sometimes patient present with nasal flaring, retraction, pallor, or lethargy. So what are the nursing care? We give the treatment as symptomatic, admin oxygen with a cool, humidified air, increase fluid intake, admin antipyretics for fever, admin chest physiotherapy, and postural drainage. So nursing care is very important. So we collect the sputum sample or provide the antibiotics, antipyretics, oxygen, IV fluid, right? So next here, if the pneumonia is developed because of atypical organism like fungal or protozoal, we call atypical pneumonia. Atypical pneumonia, acute or insidious onset, like before what we discussed. Patient presentation, sign, symptom, almost same. Fever, chill, anorexia, headache, malaise, muscle pain. Sometimes rhinitis, sore throat, and cough. What are the treatment options? Treatment is symptomatic. So you give the treatment according to the symptom. Recovery generally take 7 to 10 days. In case of bacterial pneumonia, it is the most common one. Infant, patient present with irritabilities, lethargy, poor feeding, sudden fever, or respiratory distress. Respiratory distress is a medical emergency, right? So we need immediate hospitalization of the patient and give them oxygen. Some patient present with headache, chill, abdominal pain, chest pain, or non-productive cough. When you auscultate the lungs, diminish the breath sound. In late stage, we can get consolidation in chest X-ray. So what next? What are the intervention? If it is bacterial, we give antibiotics therapy. So we start the antibiotic therapy is initiated as soon as diagnosis is suspected. In the hospitalized infant or child, intravenous antibiotics usually prescribed. Admin oxygen, place the child in a cold, wind tent as prescribed. Also suction the mucus from infant using the bulb syringe. We are talking about the pneumonia in pediatrics client. What else? Promote the bed rest, encouraging the child to lie on affected side, encouraging fluid intake, antipyretics for fever, and bronchodilator as prescribed. Also, we could monitor the temperature and prevent the seizure. And as I told you, if it is bacterial, isolation is important. Bacterial pneumonia must require isolation within 24 hours after starting antibiotics. And cough suppressant may be prescribed. Continuous closed chest drain may be instructed. Fluid accumulate in the pleural cavity may be need to remove by thoracentesis. So what is thoracentesis? It is the removal of fluid from the lungs, right? So removal of pleural fluid or air from pleural space, very important. Children with a respiratory disorder should be monitored for weight loss and for the sign of dehydration. Sign of dehydration include sunken eye, non-elastic skin turgor, decrease and concentrate urinary output, dry mucous membrane, and decrease the tear production, right? So